Good morning, everyone. It's indeed a pleasure to be here, to be able to talk about something that I get very excited and passionate about, which is ethics in small-scale communities, in rural communities, in remote communities. And as you heard in my introduction, a lot of the work that I do is academic-focused at our university and training medical students to become physicians, and I'm trying to help encourage thinking about what it means to practice in small communities. But also a lot of the work that I do is in our hospitals and in our health organizations across our province in Nova Scotia. So I get to travel across our province, engage with people, and see the kinds of questions that come up in those settings. And it's a lot of that work and a lot of that thinking over the last number of years that led to the book that was mentioned in Rethinking Rural Health Ethics. And it was a pleasure to write it with my colleague Fiona MacDonald. So in terms of today and sort of what I'd like to do in my talk, I'll add a few other notes in terms of getting started. Then I'll talk a little bit about and sort of highlight, well, what are those ethical challenges in small-scale communities, some of which would have already been mentioned this morning in the introductions. Then I want to move into sort of taking another look at that list and encourage us to think a little bit more around what are the other things that we need to notice? What's assumed when we talk about small-scale communities? What does ethics assume about how concepts translate from urban settings into rural settings or in smaller settings? How does that work? And then I'll do a little bit of a wrap-up. And I've asked to sort of get a signal when I'm on time, when I have 15 minutes or so left, so that I stay on time and keep us on time this morning. So just to sort of point out sort of where I'm from in terms of Canada, Nova Scotia is over here. Huge country. I'm working in one of the smallest provinces, but it still takes about 5 hours to drive across. That's considered small in our settings. But in Nova Scotia, outside of Halifax, by most definitions of what's rural, the rest of the province is rural. But I grew up in Ontario, which is one of the larger provinces, and have traveled across our country as well and done a lot of work in some of the other communities, in Alberta in particular. And so one of the things about me too is I grew up on a dairy farm in Eastern Ontario and in a very small community. So that feeling of everyone knows everyone, very much so. I was glad to escape when I went to university because I wanted to go somewhere where not everybody knew who I was. And then over time, you start to realize there are some real advantages when people do know who you are. And so that's kind of what we wrestle with, the anonymity that can come sometimes in larger settings, but the comfort sometimes, even if it feels a bit restrictive some days, the comfort that can come from working and living in a smaller community as well. And so doing the ethics work that I do, I've had a lot of chance to kind of wrestle with some of these different notions. For me, ethics involves, just to sort of set us up as we get going in terms of what I think ethics is, it's questions about how we should treat each other, fundamentally. The should word is the one that's the hard word, because we're not always sure in ethics what we should do, what is the right thing. As my colleagues and I sometimes talk about it, is what's the most right thing to do? Because usually if it's obvious what the right thing is to do, people go ahead and do it. They don't call for ethics or ethics help until they go, well, we're not sure what we should be doing. And so in that sense then, when I talk about what the most right thing is to do in healthcare, of course the facts matter. What's your diagnosis? Where do you live? What's your income? All of those kinds of questions make a difference. Those are facts. But the should questions are about values. They're about what's important. How are you going to make a decision about what treatment you want? Are you going to travel into the city to get health care? How long will you be in the city? How long will you be away? Are you going to travel when you know all of that? Are you going to choose to stay here? Right? Those become key questions for people that are not always obvious about what we should do or what the right thing is to do, whether you're the patient or the family member trying to make that decision, but also as the healthcare provider providing guidance. How do you support someone making those tough decisions sometimes when you know what it means to leave the place that you know? And so in this too, then, I think part of what ethics is about in determining those aspects is that wrestling when those values are in tension. It's good to stay and be somewhere that you know, but it's also good to leave to get healthcare. And how do we figure those things out? So for me, actually, a lot of ethics is about attentiveness to context. There's ethical theory, and there's sort of the ways in which we can frame out how we talk about those values. But it comes back to me about, where are you? Where are you starting from? Because the world can look quite different depending on where you're starting from, about what matters to you, what's important to you, and how that's going to relate to the decisions either patients or families, as I've said, make decisions about healthcare. It'll affect, for healthcare providers, where you provide care sometimes, your choice of where you want to practice, but also the ways in which you practice too. So, with all of that being said, I'm just going to invite you to take a couple of moments and say, if you had to write a list of your top 3 ethics issues in small-scale communities, what would they be? Before I start giving them to you. Have you got a few ideas in mind? There's a big hint in the topics that we're covering at the conference today. Got a couple of issues in mind? Okay, let's see how the list that I have compares. Is what you were thinking on this list? Yes? Okay, that's good. Yeah, because it's quite interesting. There's not a lot of literature about practicing in small-scale communities and dealing with ethics issues. The rural health ethics literature, if you will, is rather tiny compared to the vast literature about ethics in general. And so it's interesting for me when we were working on our book to, as we read all of that literature, right, the rural health ethics literature, you start to notice certain things come up all of the time that people want to talk about, or this is the ethics issues that they want to frame out. And most of them, they may be talked about in slightly different ways, but I think I've got them captured here on this list. So the top one always is confidentiality and privacy. How do you keep things confidential in a small community where everybody knows who you are? They're going to notice that your car is parked at the health center. They're going to see you walking in the door. The secretary might be your neighbor. The healthcare providers might also have kids that go to the same school as you. You go to the same church, you might play on the same soccer team, whatever it might be, right? So there's interesting questions about confidentiality in the way that we talk about it from an ethics perspective in healthcare, and certainly in Canada, it's a big C on confidentiality. We want to maintain privacy because there's a feeling that if people feel that their personal health information is secure, then they're going to trust their healthcare providers and be willing to come forward to talk about things that are pretty intimate, right? So how does that play out in a small community when the typical ways we think about confidentiality may not always work? What are the extra issues, if you will, that we need to think about from a confidential perspective? If you permit me to share a little story that really brought this home for me, is, and my dad's given me permission to talk about it, is my dad had a heart attack about 15 years ago now. He's fine, but he had a heart attack and we actually happened to be home in our farming community. It was just after Christmas. So my brother and I are sitting we're at our community hospital, very small hospital. We're sitting in the emerge area where there's about 5 chairs. And one of our neighbors who works in the pharmacy came through in the morning. And she saw us, and she said, "Oh my goodness, what's going on? What's happening?" We said, "Well, we're waiting for Dad. He's had a heart attack." She's like, "Okay, well, I hope he'll be all right," and off she went. My brother and I saw my dad, and then we went home because we had cows to milk. Somebody still needed to do chores. So it's about a half hour later we got home. One of our other neighbors was already in our barn starting the chores for us, which was lovely. It was such a gift to come home and have somebody who cared that was there. starting chores and knowing that's what was needed. Food started coming later. But the interesting thing was, I didn't think twice about the fact she went and called her husband, who called somebody else, all within that span of a half hour. So 2 months later, I'm back in Halifax, I'm teaching on confidentiality, and we're talking about, do you acknowledge people when you see them in the hospital? The typical guidance is, wait until the patient or the family member acknowledges you first, and then you can talk to them, right? And I went, wait a minute. Our neighbor came right over to talk to us, and she told people right away. So part of me goes, oh, ethical problem. But you notice how I describe her? She's our neighbor. She's not the pharmacist first for me. She's our neighbor. And it would have seemed rather odd if she said, is it okay for me to tell people? It was assumed in that neighbor relationship, we get along well together, it was assumed in that neighborly relationship that it was okay for her to share information. And yet, when I teach ethics, and I think about confidentiality, I go, where does that fit in? How do we help work through those kinds of issues? Because I don't want to go around and say, oh, it's completely fine, share what information you want. Probably we need to talk more about, is it okay for me to share this information when you get to know patients? Start it up front about what is okay to share and what isn't, and how do we maintain that approach? But also recognizing one of the ways that small communities work, this is the way that they demonstrate that they care. That it would have been really hard to go home and not have somebody help with chores. We're worried about my dad. We can't stay at the hospital because we have to do the work. So to have somebody help do that work, lighten the load, made a lot of difference. So it's one of those things that you go, it becomes very personal for me doing some of this work, but it's also an interesting tension where I'm going, well, I'm teaching one thing, but I've experienced something else that tells me there's other things that are important. And we need to figure out how to bring those closer together. So confidentiality for me is a really big one. I certainly don't want to say it's not important. Of course, confidentiality is important in healthcare. But the ways we navigate that in an urban context where we may not know everyone, likely don't know people, versus the small community where you do know the majority of people becomes really important. It's also about, and it was mentioned too, in terms of how we allocate resources. So part of the ethics of healthcare in small communities is around, do you actually have access to healthcare? Where do you go when you need help? In Nova Scotia right now, there's a lot of discussion about our emergency rooms at our small, or any emergency services in our small communities, difficulty staffing, overnight in particular. So emergencies are open 9 to 5. Or sometimes not open on holidays when everything else is closed. And there's a lot of pushback, people going, well, wait a minute, we need access to emergency care. If there's nothing else in our community because we don't have a family doctor right now, we need access to emerge. On the other hand, we can't staff it. There just aren't enough people. And not enough people that want to work in small communities. And I think this is an interesting background issue as we think about allocation of health resources. It's not just the money, it's actually the people. And how do we encourage people to work in small communities if we keep emphasizing how difficult it can be to work in small communities, right? Which is one of those pieces that I think comes up often in the literature and in experience about, it's really hard. And I'm like, but there's a lot of benefits as well. And we don't spend as much time on the benefits. So I also think access is also about specialized services. We were talking last night a little bit at dinner around centralization of services and how things are getting pulled from small communities into the larger centers. Specialized services in healthcare often have been focused in larger centers. And I'm not saying that in every small community we can have access to all specialized services, but I am intrigued with how we make those decisions. What counts as a specialized service? Surgeries, a little more obvious. Chemotherapy for some of our cancers, some of those kinds of treatments, although a lot of treatments now we can do at home. You don't have to be in hospital as long as you have good backup care available. Are rehabilitation services specialized? Some of them, maybe. But what would it mean to have rehab services in some small communities so that people can be home and continue with their physiotherapy and those aspects? It's an interesting question to both think about what is specialized and what needs to have a certain mass of people where you're treating them regularly in order to maintain a competency or a skill set, in tension with where do those people need to be? Is it always good for people to be coming into the larger centers and be traveling all the time for healthcare? And in Canada, that's big travel. It's big travel from islands. And so that question of what does it mean to be away, if we think about access in these ways, I'll come back to too. It's also that interesting part if you link confidentiality with, as we think about the therapeutic relationship, our professional and our personal lives and where they overlap, often talked about as professional boundaries. There's sort of that interesting tension of, and people talk a lot about, well, how do you do this when you're working in a fishbowl, is one of the phrases that somebody said, where everybody's watching you. What does that mean in that context? It also means sometimes if you're the only healthcare provider in your area, are you always on call? Do you get any time off? What kind of time off do you need? Can you take time off in your own community? Do you need to go away to have time off, right? Are some of the questions that come up. And then different understandings of health for yourself and for your community and how that connects to issues of stigma. So one of the examples that my colleague Fiona, having worked in Australia, during times of drought, the number of suicides by farmers when their livelihood was threatened, they said, well, obviously it's because there's drought, they're losing their livelihood, but it was also a part of sort of that rancher self-reliance. I'm in the outback, I can take care of myself, as long as I can do my work, I'm okay. Ranchers like me don't have mental health issues. They realized that that kind of, as they said, macho attitude was actually playing into the lack of people turning up for healthcare when they needed it. So maybe actually contributed to the number of suicides, right? Mental health is often one of the ones in smaller communities that people are really concerned about in terms of wanting to seek out help, but also fearing the confidentiality piece. But also we know with mental health generally the stigma that comes with it, whether it's in a large center or a small center. And so needing to think about issues of stigma along with that, and certainly there's other issues we could look at there. So making sense as a list? Lots of different things. I'm starting to give a few hints about stuff that I might wonder about in it. But as we go look at it, I encourage you to think about that list and say, well, what assumptions are being built in? What assumptions are being built into that list about small-scale communities, about rural and remote communities, about the nature of healthcare ethics itself? And this is where I like the rethinking idea. Do we need to take a closer look? I think it's obvious that my answer is yes. And what I'm going to do is take you through 3 different ways of taking a closer look at what's going on with this list and the ways in which we think about healthcare ethics and challenges in small communities. One of the first things is to notice how often when we talk about small-scale communities that sometimes there's very big stereotypes about them that are at play. And we call this both the deficit perspective and the idyllic perspective. The deficit perspective is the one about everything is less than in rural communities or remote communities. So you can't possibly get good health care in a rural community. Anybody who works as a healthcare provider sometimes in a small community means they couldn't work in an urban setting I've heard people say that. Like, okay, what's going on, right? The assumption is that rural and remote and small communities are always coming out less. And we emphasize, right? And if it's taken to the extreme, the deficit perspective just sort of says, well, why would you ever want to work as a healthcare provider in a small community? Because you're faced with all of these challenges and problems. I certainly don't believe it in that way, but it's interesting that it kind of takes root, and it's actually a very good political argument for saying this is why we need more healthcare in our area. Because our health rates are poorer, usually in smaller communities. There are facts of the matter that health is less, right? People are not as healthy typically, by certain measures, in small communities. And so there is a political piece around, if we emphasize that and say, well, we want to boost our health, increase the amount of health that people have, then maybe we can get some more resources for healthcare in small communities. So there's some interesting pieces to the deficit. My concern is really more around if we keep emphasizing that, we lose sight of all the things that are good and are valuable from an ethical perspective about working and receiving healthcare in a small community. But contrast that with, and I'll come over this way, on the other end of the spectrum, the idyllic. Looking out these windows, it's not hard to see where the idyllic comes from, right? There is that picture of living in a small community that is very peaceful, pastoral maybe, ocean-focused, and then you think, must be so nice, right? And it is nice to live in small communities. But if we use that only, it becomes a very uncritical way of thinking about some of the complex challenges that small communities are facing, right? Because the ideal says, there's never anything wrong in a small community. Well, that's not quite right either, is it? So I think part of it is to think about, as we look at that list, what are the tensions around the deficit and ideal that people are playing with as we talk about some of those ethics issues? How are they playing into what gets focused on or talked about? And I think in that spectrum, you need to be moving back and forth between both of those notions. Does that make sense? Yeah. So there's one way of starting to challenge it and look at it, right? Because in that sense then, right, the deficit is everybody knows everybody, can't keep anything confidential. And there's almost implicit in some of the literature a suggestion of, why don't these rural people understand the value of confidentiality? I'm like, I actually think they do understand we I understand confidentiality, but you might make different trade-offs about that, how important that confidentiality is to you in order to receive the benefits of living in a small community. That's the part that gets left out. That's the part that we need to talk a little bit more about and sort of figure out. It's not just people that you just say, oh, well, or we don't want people saying, well, then it doesn't matter, we don't need to keep anything confidential. Not right either, right? So that's the deficit side. The other is, and do you feel this is true? Small communities always take care of their own? In a lot of ways, yes. Coming from a small community, I want to say, of course we do. The hard fact, though, is not all communities can take care of each other. Not all communities, small communities, are thriving. Some small communities are dying. People are leaving. It's also the case that if you're a member of the community that nobody likes, is that small community going to do the same as they did for me and my family? People won't show up in their barn to do chores if they don't like them, right? And it's not about being popular. It's actually about sometimes those stories that take root in communities about this is that family. And when you think about how we try to deliver healthcare and the high reliance we often have on informal caregiving through your family and through others in your community, we need to be cognizant of the fact of, is that including everyone? Will some of the most vulnerable members of your community actually get the care that they need if they're not the popular person, right? Or if they're excluded from their community? So again, sort of the tension on the idyllic part is one of those things that we need to be conscious of too, because a lot of health policy, I think, is built on the fact that small communities will take care of their own. And I'd love to say we can always live up to that, but I'm not sure we always can. And literally in terms of the number of resources that we have as well in communities to do it. So, some interesting tensions to look at there. The second one is, as we start to look at, and I've already hinted with my discussion about confidentiality a little bit more, as we look at sort of our traditional ethical theories and approaches, the ones that we use most often, are you familiar with principalism? It's sort of one of your key focuses. It's one that people use all the time in Canada. So it's the 4 principles of respect for autonomy, beneficence, non-maleficence, justice, right? So principalism by Breacham and Childress, they developed those principles from an ICU context, from a critical care context. And that's fine. I think that's important, but recognizing the fact that they developed those principles and the kinds of cases that they use to demonstrate how those principles work are pretty much all acute care based. Big hospitals, tertiary level, specialized services. ICU is pretty specialized. How do those principles translate then in a small community? Do they apply in the same way? Is there anything that's missing if we look at it from that perspective? And certainly from the bioethics community, many bioethicists, and certainly the largest proportion who've been doing writing, are urban-based as well. And many of them come from urban settings, right? So there's an interesting way in which I am wondering about how an urban-centric perspective filters into our ethical theories and approaches. And the way that that comes in is then that becomes the norm. This is what ethics looks like. This is how confidentiality operates. So anything that doesn't operate like that is different and potentially less than, not as good, not as right. And the way that I think it's important to look at as an example, right, as we think about how it helps us, or that urban-centric bias maybe characterizes different problems that we see from an ethics perspective, is to think about the fact that much of ethics is premised on treating strangers. It's really an ethics of strangers, where we say, trust me because I'm a doctor. Don't trust me because you know who I am. Trust me because I'm a health professional, right? So a lot of the ways that we train our health professionals is to inhabit and take on the professional role. Very important. You do want people to have trust in healthcare providers, whether you're a nurse, occupational therapist, spiritual care, whatever it might be. We want to say being a professional means that you have certain competencies and you follow certain ethical requirements. And so it means when people are strangers, I can trust you because I know you're supposed to have my interest at heart as a patient, right? Making sense? You can see maybe where I'm building, right? Then it becomes, well, how does that frame how we think about professional boundaries? So professional boundaries, right, maintaining that personal and professional as separate. Much of the literature and many of the codes in different professions talk about professional boundaries as they should always be separate. You should keep your personal life separate from your professional life. Well, that's nice if you can do it. From a perspective of a small community, is that possible? Not really. I've had some people kind of joke and say, well, basically I would have to be a hermit in my small community, order in everything, never see anybody, in order to make sure that I never have an overlap of personal and professional, right? Well, who wants a life like that? Not many of us. Hermits are fine, but not all of them will necessarily be good healthcare providers, right? Because you need that connection to people. So it's sort of interesting that it sets the norm of keeping them separate as ethically best. And if you have overlaps, then it's like, uh-oh, you've got a problem. Right? That's that deficit perspective coming in a little bit. I actually think I want to flip this around a little bit. I actually think this is the ethically easiest. If you work in a large center where you can actually keep your professional and personal lives separate, that's easier. You don't have to face the ethical challenges of when they overlap. So ethically easiest doesn't mean bad. It just means that you don't have to confront those types of ethical challenges as often, right? So even though they set it up as best, I actually think it's the easiest. And in that, I think we need to start talking about overlapping, dual, multiple relationships as a norm. From the perspective of small-scale communities, that's the norm. It's going to happen. It's going to happen often. It's probably going to happen in ways that you don't expect. So how are you going to navigate the challenges that come up around what do I keep confidential in my office setting, and how do I do that when I'm at church? When I'm at school, when I'm walking down the street and somebody stops me and says, "Can you tell me about this? How's so-and-so doing? Do you think I should adjust my medication?" Well, is this really the right time when I'm running home with my groceries trying to feed my children because I'm late? Right? How do you navigate that in a way that still says, I care about you, but keeping that professional in another place, or we need to have that conversation at another place, right? I think we need to revalue those relationships, because sometimes actually when you know somebody out in other contexts, when you know when they're from, when you're from the same place, there's ways in which that can actually improve your ability to connect. And it's also about being known and trust. That somebody will trust you because I've seen you. I know how you behave. You're reliable, right? And I think those are important ways that we don't always appreciate how valuable that can be and how people assess. I'm going to come to you to talk about my mental health issue because I know you don't treat anybody differently, right? So I think there's those kinds of ways that don't show up in the literature, don't show up necessarily in our teaching, that we need to start to talk more about. And I look forward to hearing about strategies that people use to navigate and manage these different relationships and the overlaps between them. I also think the third part is there anything else that's missing in terms of those core values, right? The values that we talk about a lot in healthcare, right, as the principles. I think, well, there's something different about the way patients talk about how they make decisions in healthcare, and the reasons why people value being in a small community and how that relates to what they think being healthy means or the choices they're going to make about their healthcare. And that's where I want to talk about place and community as values. Not just as concepts, but as something, as a value that people are using. And by value, I mean it's that they're using it to make decisions, right? So if we look at place, a lot of people from small communities talk about being connected to that place. It may be geographical, it may be a certain scene. It gives you a sense of belonging. It's a sense of identity. This is who I am, this is where I'm from. When I'm here, I'm me, right? And in that sense, when it becomes a strong part of someone's identity, I think it becomes morally relevant, because they're going to be using it more explicitly or implicitly to be making decisions about healthcare. And so in this sense then, when we are asking people from small communities to travel or having to leave the place where they are to receive healthcare, I think we need to talk more about what does that actually mean. In Canada, we focus a lot on, can we get you from A to B? And who's going to pay for A to B? We spend a lot less time thinking about, well, what does it mean to be dislocated, to be uprooted? But also, what does it mean to return to one's place? If you're returning home well, if you're returning home still needing some health care and having to travel again, or if you're returning home to die. Being in one's place, and being in a place that makes sense to you. Do we put enough attention to that in our healthcare policies? Because if we can get travel paid for, that's one piece of it. But the other piece is, what does it mean? How do we help account for or make some of those connections back to place for you? Would it change what we think about the value of being in one's place. Connected with it too, and as I've talked about a lot already, in some ways is about the value of community. So if you, just as a recap, sort of often we assume, certainly from healthcare policy, that communities are cohesive, care for their members, right? And yet, as I've said, not all communities are cohesive. Not all of them are able to care or willing to care for each other. They don't all have a shared set of values. There's a lot of variety within small communities too. People tend to think, oh, well, you're from there, this means you must believe this. Well, it's kind of like saying all Canadians believe in public health care. Yes, we do. Right? Yes, but when you actually look at health policy and what decisions people might make, you start to see a lot of variation, right? And sometimes we lose sight of the fact that small communities can be varied as well, right? Key part of it. But I think for some other folks too, community plays out in another kind of way, which is it's part of who they are. They want to be part of a community where it's a sense of solidarity. We're in this together, right? This is who we are. We're in this together, I'm part of this community. Or it's also that sense of reciprocity, right? Small communities are, well, give and take. You do this for me, I'll do this for you. Eventually it'll all pan out in the end, right? And that's how small communities work. People need to take on different types of activities at different times. Somebody needs to do some of the work, so let's play it out. Well, again, it becomes part of a value for some folks. So I think also, again, when we're talking about healthcare, especially if people have to leave to receive some forms of healthcare, what does it mean to not want to be a burden on one's community? At the end of life, we often talk about people not wanting to be a burden on their family. I think there's another way it comes up in small communities where I don't want to be a burden on my community, especially if you've got a lot of that informal caregiving network going on that extends beyond your family. What does it mean to feel that you owe somebody a form of caregiving? So if somebody's helped you travel and has done a lot for you, has done your chores in the barn, what does it mean if you feel you can't reciprocate? How does that play into your decisions about healthcare? If you want to be able to give back in some fashion. And what does it mean if you lose connections to your community? Often people will say when they've traveled into Halifax for healthcare and then having to go back, if they've been away for a long time, they're kind of out of the loop. What's going on? Who's had a baby? Whose house is burned down? Whatever has gone on, right? And there's something about being connected to your community in that way that helps people, I think, have a bit of resilience. A feeling that they belong, a feeling that they matter, right? And it doesn't mean that that doesn't happen for urban folks. Of course it does. Place can be important to them as well. But I think proportionately we see this show up more and more in people from small communities because there's that sense of being close-knit and understanding what the impact of some of these decisions are on people. And so in that way then, in terms of wrapping up, if you're with me on this journey around the ethical challenges of small-scale communities, I think there's a lot more that we can do and a lot more that we can talk about in terms of the ethical challenges we face. Today is going to look at, in depth, some of those key challenges that were on my list and I know are in the conference program, which is fabulous. But I also think there's the other ways, if you take a broader look at it too, is to think about where does this fit into our education and training for future healthcare providers. Most of the cases we use are urban-based. When you look for rural or remote cases, there's not as many. And I think we need to be careful about some of the cases because they always convey a sense of deficit and don't actually balance out with some of the strengths of rural and remote communities or small communities as well. And the ways in which they're unpacked maybe miss that sense of place, that sense of community, and how that can figure into decision-making about healthcare. I also, in the longer run, I'd really like us to start to challenge some of our traditional approaches to healthcare ethics. It's not about discarding them, because there's lots there. It's actually about how do we enhance them and build in a richer sense so that those theories and approaches that we're using help inform both for small-scale communities, but I think, especially around professional boundaries, help inform our urban folks as well. Because I think there's things that they can learn from small-scale communities and how we navigate that personal and professional those personal and professional aspects so well, so often, that that can actually be useful wherever you practice, right? Because urban-based folks do see personal and professional overlap sometimes. So why not show them the advanced skill set that has come from working and figuring out ethics issues in a small setting? So with that in mind, then I'll just sort of say, no matter where you are, and no matter where you're from, if it's a small-scale community, hopefully this has given you something to think about in terms of the ethical challenges in these settings. Thank you very much. Okay. Good. Good.
Yeah, thank you very much, Christy. So thank you for an excellent presentation that I'm sure raised lots of thoughts and questions about connections with our own experiences and views about these matters. Now we are still a little bit ahead of time, so luxury continues. Yeah. The idea was to have about 15 minutes of question and answers, and then we break for coffee, and then we continue with the session. We can give ourselves at least 15 minutes. Sure. Yes. So, who wants to be first? Yeah.
Yeah.
Thank you, Christy. It was really a pleasure to listen to you.
Thanks.
And you are a storyteller too,
yes,
so which makes it really nice.
Good.
I don't really know whether that's a question or not, but there's something I've always wondered about, because, and it relates to resource allocation. Because we always hear and we know that healthcare professionals working in large cities are very stressed, work a lot, work all too much. Yep. And I'm pretty sure that many of them have fantasies about having a different life. Yep. And at the same time, as you said, it's really difficult to get people to work in small-scale communities. And I've always wondered why. What is the main reason? Is it a financial reason? Because it's difficult. I know, for instance, for general practitioners, it can be very difficult to establish a practice in a small place because you need to have a funding, etc. Is it a matter of stereotypes, as you said, that people misunderstand what it's like to work in small-scale communities? Is it a cultural issue? I know that in Norway, for instance, young doctors are often sent out to the northern part of Norway or small places to start their practice and are struggling to, understand how things work in the small-scale community. We have issues of dialects that are difficult to understand. So Norwegians themselves have a hard time understanding it. So I've always tried to understand what really is the key issue of why it's so difficult to get people to work in small-scale communities.
A great question. And I think you've actually hit on a number of the factors that actually relate to that, because I would say it's not one thing that makes it hard to get people to work in rural areas. I think it's all of the above. And certainly the literature kind of shows money, you can increase the money, you can give people bonuses to work in small communities, but money alone doesn't keep them there. So money is a great incentive, especially if you're paying off student loans or something, right? In Canada, that's a big part of it. But it doesn't mean you're always going to stay. A number of people will say, are there opportunities for my partner to work? Right? So actually, I think that is one of the factors for a number of small communities, is when we're thinking about recruiting, are we actually thinking about, are there opportunities for their partners as well? And not everybody's looking for that, but for those that are, that becomes significant. Some of it's about education, about what education opportunities are there. And so you can keep going through the list. But I think there's a couple of things that we haven't looked at as sufficiently. One is, there's some literature that suggests that if you're from a small community originally, you're more likely to return to a small community, not necessarily to your own, but to practice in a smaller setting. And I think that sort of helps me understand, if you understand how small communities work, it's actually a little bit easier to start a practice there, because you get a sense of, I need to figure out some of these challenges, right? I need to be thinking about, I'm going to run into people all of the time. And I think for a number of our students that come from urban settings, we set them up for failure sometimes, because we don't actually teach them some of those things about, this is how you need to figure out how small communities work. You need to think about who's in a municipal setting, get to know those folks, because that actually can help you set up your practice, right? Making those kinds of links that you don't always need in urban settings in the same kind of way. So I think it's some of those teaching strategies that are a part of it as well. The other thing that I think we're seeing that is a harder one to get at is, I think from a small community perspective, we've been used to having the same, and it's usually physicians we talk about, the same physician for the whole lifespan. So those physicians that practiced in the same community for 40, 50 years, sort of saw delivered you as a baby, now as your physician. It's very attractive because people say that's great because they know us and they're part of the community. But all the signals are the newer workforce doesn't want to stay in the same place forever. And so there is that other part around, we need to adjust our assumptions too about what it looks like for 5 years, for 10 years, for somebody to come and work in a community and then maybe change. It doesn't necessarily mean we've done anything wrong or haven't welcomed them, but actually that it's a sign of people are moving jobs much more frequently. And that's the part that I'm not sure, especially from a Canadian perspective, that we really have grappled with, because that stereotype of the person who is always there is still in our heads. And I think sometimes that is self-defeating, because people feel the pressure of that. If I'm choosing to come and work here, then I'm going to be here forever. Well, I've just barely got out of school. How do I know if I want to be here forever yet, right? And so I think there's another way that we need to be conscious of the pressure that we put on some of the healthcare providers when they come to small communities too, about people will give signals of, we're expecting you to be here forever. And that's hard as you're setting up a practice to always think about. I don't know, does that get at some of the other, yeah, but I think there's so many different layers of it. And I also think, even though there's the signs of people that come from rural communities tend to practice in rural, we also don't want to just put the burden on all of them to take on that role to work in small communities, right? So I think there's also that messaging that happens in medical school too, around the value of general practice, about what it means to be a family physician, that we've seen our rates of people choosing to go into family medicine at Dalhousie go down. And now they're trying to counter that, because there's some stereotypes about, well, only if you can't make it in a specialty, then you choose family. I don't think that at all. But if you're getting told that as a student, then people are going to choose different specialties over it. And I think that's another piece that we need to grapple with too. Yeah, does that?
Okay.
Yeah.
Thank you.
Big
Thank
question.
you very much.
Yeah.
Other questions? Well, yes.
Yeah.
Hi,
Hey.
I'm Simon Woods. I'm from Newcastle in the UK.
Okay, great. Hi.
Really good talk, thank you. It was
Thank
really
you.
interesting. Do you have any kind of working definition of what a small-scale community is? Because it seems
Yep.
to me that,
Yep.
yeah, you can have the kind of remote village
Yep.
idea,
Yep.
and Canada is a nice example of what
Yep.
could be remote, but I think there are plenty of small-scale communities in very urban settings. You know, UK is densely populated, but
Yep.
I think these small-scale communities are configured in different ways in different contexts.
Yes, yeah, and I would absolutely agree with you on that. One of the things and I appreciate you bringing it up, because one of the things I didn't talk about is, another thing you could add to the list is, what's the definition of rural or small-scale community? Because there's no one definition that everybody agrees to. Governments may define it by how many people per square mile or square kilometer. It may be distance from certain types of services. they all vary according to different countries, absolutely. And I think there's a lot of really interesting literature coming out of the UK that really speaks to what you just said, that some of it isn't about, well, I have to travel 5 hours, but even traveling sometimes half an hour is a big difference, right? Because I have to travel. And so so part of it, I think, for me, at the end of the day, is if you think you're from a rural or small-scale community, you probably are, right? In that subjective kind of sense. Because I think it's the subjectivity of that perception of what's rural, about what's far, about what's small, that for a lot of the ethics work becomes really relevant. It becomes important. Because pointing to that and saying, well, you actually only live half an hour away from the specialized services, like get over yourself, it's not that far, that doesn't change that person's experience of what it means to travel that far, or to feel away from their community, even if it's that distance, right? And so I think that's the subjective piece that the ethics of small-scale communities and looking at it in these ways can kind of embrace, in a way that maybe how our governments use different definitions to allocate taxes, and those things are a little bit different, yeah.
Yeah. Very interesting, those, how rural, I mean, you think in terms of geographical distances, but maybe if you think not place, but community, then it can be cultural distance that you have to travel. So maybe just a 5-minute walk in an urban setting from the perspective of a minority, small minority, close-knit community might still be a barrier that is comparable to the rural-urban distinction.
Yeah, absolutely, absolutely. And I do think there's a little bit of stuff that's coming from some of the smaller communities within large urban centers that I think does actually parallel just what you said. That health geography kind of perspective is starting to get, to start to talk about how different it can be and what those barriers are. Yeah.
So, more questions? We have a little bit more time, so if someone... Janne.
Hi, Jan Nikkinen from Finland, Nordic Committee on Bioethics. I was wondering, there must be clear examples of the services that you really don't need so much in small-scale communities, like what comes to my mind, like the addiction services. Many drug users go to cities, they tend to concentrate on these kind of urban areas. So, but are there other examples of services that are not simply needed in?
Yeah.
Because it's not always that everybody has the same services across the sparsely populated country like Finland, because it's the epidemiological fact that you focus the services where they are mostly needed.
Yeah, no, it's a great question too, right? Because one of the interesting, so using addiction services as an example, in a lot of our remote territories, which are primarily indigenous communities, there are serious addiction issues. And there has been a lot of conversation around if you need fairly specialized services to manage addiction and to address sort of the deep-rooted trauma that those communities have experienced, we're not providing it in those settings. People are traveling hours and hours to get those services, and usually they stop because it just doesn't make sense. And so it's an interesting one to start to push on, rather than making blanket statements as a country or as a province saying, we do this only in urban and we only do this in rural or remote, we actually need to look at what are the needs of the population and maybe think about how do we distribute our services in different ways. And Alberta, for example, one of the things that they've started doing is instead of having everybody come in to see the specialists, they're actually trying to rotate the specialists around. Maybe not getting out to all the small communities, but getting out to more regional areas so people don't have to travel as far. And that's actually been fairly successful in terms of, it's nice having the specialists come closer to you. And so I think for me, there's an interesting way that it helps to build some of the relationships that are needed for some of the specialized kinds of care, like addiction services, some of the counseling and psychiatric services and those aspects. So addictions and mental health services are ones that I'm particularly attentive to. And I know we're looking at sort of telemedicine and some of those aspects later about what can we deliver at a distance and still be effective. So the initiatives around looking at psychotherapy over, maybe not Skype, but something, a telehealth connection those ways, maybe that's how we can deliver some of the specialized services that aren't as equipment heavy, if you will. Beyond that, I think certainly, I think having access to primary care is something that we really do need to take more seriously, because primary care is that one that if they can, and often a lot of focus of primary care is also health promotion. So if we can help prevent health issues before they get really bad in smaller communities, that actually means fewer people that have to travel or have to look at other kinds of services. I think rehab, as I also mentioned, I think that's another one where we've assumed it's always specialized and needs to be in an urban location. I think we actually could look at the model and think about what can we deliver more in smaller communities too. Maybe not in every single one, but certainly in some with that. I'll think some more about it, but yeah, but does that get at some of what you were? Yeah.
Yeah. Thank you.
Good.
Kirsten?
Thank you. I'm Kirsten Kyvik from University of Southern Denmark and the Nordic Bioethics Committee.
Yeah.
And I've been sitting here thinking about how important teaching is. Yeah. It was really an eye-opener to me what you said about the ethics of healthcare being set in the urban setting. This is, I guess, more a comment than a question, but I can't help thinking that there are recent papers demonstrating that during medical school, we are actually taking empathy out of the young people. So we have to develop the teaching so that we take all of these problems into consideration, I think. And that's important for all of us who work in healthcare.
Yeah, absolutely, and that's one that cuts across wherever you practice, right? We want empathy to be part of that. And it is, I mean, I'm certainly with you around the education piece, that I think the more that I've started to do this type of work and to really think about it, the more convinced I am that we need to find ways to introduce it into the curriculum. But interestingly, even at Dalhousie where I am, and I'm there, it's incremental. It's where can I get buy-in from who? Because then we can start to work on some cases and introduce it in. We have a rural week where our students go to different rural settings, but we don't talk as much about the ethics issues as part of that. I'd love to see that introduced, right? And I think part of it is connected to the point about empathy, is if we're setting our students up and saying, go to this rural community, go to this urban center, but we don't provide you with the tools to do that work or to help to kind of go, this is normal. These are things you're going to struggle with. These are questions that are going to come up. We kind of imply, well, you should be able to figure it all out, which I think in some ways decreases that empathy towards themselves and that understanding of themselves and compassion for themselves, which then means if I don't feel it for myself, it's harder to feel it for my patients, right? And I think it's something in that that expectation of perfection, that you should know all by the time you're done medical school, is something that we need to work with a little bit more around that, which I think can go to both the empathy piece and the rural health ethics piece as well.
Yeah,
great.
Thank you very much. Eva?
Great.
Yeah,
there we go.
Yeah. I was thinking about the question of why is it hard to get healthcare professionals to more secluded areas or small-scale communities. And I think one of the things you've probably not addressed, but I think could be important to address as well, is the fact that it may be actually quite lonely to be the healthcare professional, whether you're a doctor or whatever, because you have to, you know a lot of things about these people, and you're not really allowed to share it with anyone, so you sit there with a lot of, in a very lonely place actually. So that may be some of the things that you were talking about addressing. What does it mean to be in a small-scale community? Teaching more about how to deal with it.
Yeah.
That could be one of the aspects also necessary to deal with.
Yeah. No, that's a great point. Because I think there certainly is, people do talk about that exactly in that way, that it feels lonely sometimes, because who can I share that with? Where are my colleagues, right? Yeah, you're a part of it, but you're not part of it, right? So yeah, absolutely. And I think I've seen different strategies that people use for that. So some of it is finding colleagues who also work in small communities, and they set up regular times to chat. So even though it may not be physically present, finding a broader online community that can help with sharing some of those stories and sharing resources. But you're absolutely right. And I think connected to that, one of the interesting ones that has come up as well is if you're single and you move to a small community, are you able to date within that community and find a partner? In one province in Canada, they used to have the rule that you could basically, if you had any possibility of a therapeutic relationship with someone, not currently, but in the future, you really shouldn't you shouldn't date. And people were going, so I have to go 2 communities over, maybe, to start to date. And I think it gets to that point of being lonely, like lonely from a professional perspective about who can I talk to about what I'm experiencing, but also lonely from a personal perspective and going, is that really what the expectation should or shouldn't be? Of course, we want to be careful of people who are there to exploit, right, and take advantage. Absolutely, we need to be careful about that. But most people are going, this is how I feel at home. This is what makes a community, is that I'm actually part of it. And sometimes one way of being a part of it is finding your partner, right? And being part of the community in those ways. And so I think, there's, again, adds to that question. So thank you. Yeah, there's those other ways to expand that picture of what we're looking at.
Yeah, thank you. I really liked your distinction between the deficit model and then the idyllic model, right. And both are kind of exaggerated and one-sided. And it's common, I agree, for the discussion to really be based much of on the deficit model, where the assumption is that the quality of the services are bound to be lower, and so you are sacrificing something in a way by living in a rural setting. Choosing to move there has to be something offsetting it. The idyllic model tries to deny that, but you cannot do that simply by denying it. But I'm wondering if you could say a little bit more about, realistically, what could be said if you wanted to highlight some of the opportunities for improved and increased quality that lie in precisely the small-scale setting. You see what I mean? That some of these, for example, you talked about the motivation and connection of a neighborly relationship. I mean, isn't that a positive factor? I mean, how can things like that be turned into a source of value and quality in health services? You see what I mean?
Yeah. No, and that's where I didn't expand on it as much in my talk, but that revaluing of relationships is, I think, both from a philosophy perspective and from a healthcare ethics perspective, we've tended to be, or the literature tends to be, fairly suspicious of relationships, right? That relationships are the things that are so subjective, and it will negatively influence my opinion as a healthcare provider. I think in a lot of the stories that people tell in small-scale communities, it's actually the opposite. That they go, because I know who my physician is, because I know who my nurse is, and because they know me not just as a patient, but they know me as a person, and they're part of us, it's actually, I think I get better healthcare, right? Because I'm not some stranger to them. I'm actually somebody that matters. And certainly a number of healthcare providers will say, you get to see the results. There can be real satisfaction in doing work in small communities because you can see the benefits. You can see the results of when you make a difference in somebody's life and their health improves. You actually get a lot of that feedback. Now, yes, you can get when it's harder too, but I think that for a lot of urban professionals, they don't always get to see the outcome either way. And in small communities, you can see the outcomes. And I think that's a real benefit that we don't actually talk about a lot and sort of put into practice. And my brother actually is a physician and works in a small community. And it's been it's fun because when he was going to the Home Depot, right? Sort of going to Home Depot to get carpentry supplies and those things. And the fellow said, "Oh, well, I saw you in Emerge. You were my physician a couple of weeks ago. Thanks so much. It went really well. Things went really well. It's great to see you here. What do you need help with?" And rather than being an awkward kind of exchange, my brother said, he goes, "Well, that night Emerge was so busy," he said, I didn't remember his face. But when he said, "This is what it meant to me that you cared for me," he said it was so nice, like it was an unexpected bonus of going to get carpentry supplies, and he finds out that he did well by somebody, right? And I think it's those kinds of stories that we can pull out as well, that help to add that broader context to that story, to that broader picture,
Right. And related to that, it would be interesting to know, I don't know these numbers, or if there are studies that compare burnout rates in urban versus small-scale settings, because you mentioned burnout as a potential danger in the small community, but it could be, I don't know, it could cut both ways, you could say that.
Yeah, and I think I haven't seen anything that talks about it this way, but I think the burnout that people experience in urban settings may be for different reasons than in small communities, and I think that's important to notice as different societies are starting initiatives to address burnout with their professionals. So physicians are talking a lot about burnout and how do they address it, and I'm like, but your strategies maybe need to be different depending on which physician group you're talking about.
Right.
Yeah.
We're almost time, but I have one more question. Yeah. So, and I have 2 more minutes before coffee.
Okay. All right.
So, yeah.
Yeah. No.
Hi, I'm Rita Salmarin from Finland, also a member of Nordic Committee on Bioethics.
Yep.
And maybe this is not the right note to end this session, but I just wanted to ask whether you feel that there would also be an ethical question about. Well, honestly, not all clinicians are equally good. And there may be people who in a very small community, you may be very much, you have a gatekeeper there, especially in public health systems, who actually and they are an authority in the small society. So I'm just wondering whether you feel that this is an ethical question as well, that some people just, even if they know the whole family, they have seen you all their life, they are just not very good at their jobs. And there might be a better person, a better clinicians 20 kilometers away. But how do you know that? You wouldn't know that. And it's also going to be a very big question in the community if you actually start to question that authority.
Yes.
So do you feel this is an ethical question?
Yes, absolutely. Yeah. So the quick answer is yes, it's definitely an ethical question and something that we need to be looking at. And I think we, meaning sort of from ethics communities or ethics committees, but I think we also including professional societies and the regulatory bodies, because there's if you look at the number of reports or complaints about urban versus rural physicians, they're roughly the same. So it's not suggesting that we're seeing worse clinicians in rural areas versus urban or vice versa. But I think what you're pointing to is that the impact of a poor clinician in either setting can be quite different. Right? So a poor surgeon, there'll be sort of things that monitor and capture that in a particular way, and there can be very bad outcomes from that. Absolutely. But in a rural setting, if it's the person who's a gatekeeper who maybe takes a dismissive attitude towards mental health issues or hasn't kept up with their competencies, right, and sort of the newest things, they can actually be very harmful for the whole community, right, broadly speaking, and particular individuals within that. And I think it's a really interesting one around, even though I mentioned complaints, part of that is premised on the fact that people know they can complain, right? And so there is an interesting question for me about whether everybody, generally speaking, knows that they can complain or go to regulatory authorities or report someone, and what might hold people back in a small community from doing that. So there's a great paper that came out several years ago now, but it sort of talks about, is anybody better than nobody? And there is that interesting question, I think, for small communities, which is, are we willing to take somebody who's not as good so that we have at least something, versus not having anything at all? Very ethical question, right? Lots of different things in there. I think for me over time, I'm becoming more, sometimes actually no care is better, which seems odd to say. I don't want no care for a long period of time, but I think the harm that you're speaking to that sometimes can be done with somebody that's poor actually can have much longer lasting effects than needing to manage a short term without anybody, if that makes sense. Yeah, and that's the crux of that kind of question. Yeah.
Very interesting. We're going to have to
Sure,
end on this somber note.
That's okay.
Yeah.
That's good.
Christy, thank you
You're
so
welcome.
much for your absolutely terrific presentation and discussion today, and thank you all
Thank
for
you.
good participation. We will
Yeah.
break for 20 minutes, so our next session will start here at 10:50. 10:50. Okay, thank you
Great.
very much.
Thank you. Thank you, everyone. Yeah.